So the next few minutes I'm going to spend going into some of the tactical details of what are the data requirements under this CMS-0057 mandate enforced in 2027, and go through this for a number of the key areas of how do you get that comprehensive trust data set from a number of angles that underpins each of those access APIs. So this is intended as an overview. You could spend an hour on each of these, but I'll try to give a quick justice of like what CMS is requiring in this rule, what implementation guidance there is it recommended, is it required, any changes since the first go round of CMS 9115 back in 2021, which I'm sure a number of you are well familiar with from a few years ago. So jumping in, I think the first data type I'm going to talk about is one that's actually net new for CMS 0057. And so this is an important one, given there was no requirement a few years ago. And so this will kind of be net new for everyone, regardless of kind of what you did back then. And so what's being required is you load active prior auths that have any kind of updates within the last calendar year of that request. And some of the specifics would be kind of the related structured as well as some unstructured data around administrative clinical docs that support that request and how it was adjudicated. Further, for each of these requests, there's kind of the status. Is it pending? Is it final? Was it approved or denied? And dates associated with that. And then any circumstances of why a prior auth may have been approved or denied. And for denial, there's even more specific requirements around specific reasons for that denial. So all of this is kind of is net new, and to help kind of guide what gets loaded, CMS has recommended a implementation guide that DaVinci has put out under the PDEX implementation guide, or IG. And so this is one that is still a draft and kind of in going through the ballot process like IGs do normally. And it's one that we are closely monitoring as at OneUp, where we are actively engaged in the DaVinci work groups, burden reduction and payer data exchange, and are actively monitoring and collaborating with others in the industry as this IG gets kind of memorialized and goes through the ballot process. And we're going to keep you updated as that progresses. But that's kind of a preview of what's to come. The next data type I want to cover is kind of bread and butter, right? Claims. So this one is really kind of a continuation of the requirement from 2021 with 915 for any adjudicated medical and pharmacy claims, as well as encounter data. And so all of this has a requirement of data going back to dates of service January 2016. I think what has changed is CMS is recommending a more recent version of the Karen implementation guide for Blue Button, which again, we would have loaded back in 2021, a earlier version of this IG. And so just to highlight some of the changes of what's happened since we first loaded that data back then, there's more specific guidance for dental and vision, which is helpful and kind of based on industry feedback. And there's also a related person profile, which is when there are other parties involved in a claim that may not be the member or the physician. So kind of more helpful guidance there and supporting those types of use cases. And then like all IGs, they generally get cleaned up. There's minor updates and technical corrections. So, that happens as well. But the meat of it is those first three on the top right here. Clinical data. So this is obviously a kind of a potential much larger scope of data, where CMS is looking for loading, like with 915, continuing the requirement of all clinical data maintained. And so they reference the US Core Data for Interoperability data set, USCDI shorthand, which is a wealth of kind of holistic longitudinal data from a clinical side, from care plans, conditions, vital signs, observations, and more. And so it's kind of any of those data types you might have today. CMS is looking for you to load those. And again, there's kind of a similar going back to 2016 and forward as that line in the sand that they're calling for. And I think here, this is a kind of unique to the other areas. This is actually a CMS is requiring a standard here. So beyond just R4, they are actually requiring US Core 311, which is a kind of, it's how FHIR data is represented in the United States. And other IDs that we'll talk about, like DaVinci PDEX and PlanNet and Karen, they actually use this as to inherit from as a foundation. And so this is kind of a floor above R4 that CMS is requiring. And while the rule, when it came out, required 311, there also was a footnote, a very key footnote about the intention to align with ONC, which also requires US core and actually is moving that target, that baseline floor up to a more recent version 6.1 starting next year and beyond. And so here we're kind of looking ahead, and we'll talk about how our extract guides and how we'll help you load data that kind of future proofs you and gets you ahead of some of these future requirements from ONC and CMS. Really, what's changed since 915, the first go around here, is with that US CDI data set, there's been a strong focus on health equity and public health. And so that comes across in a number of data classes and elements related to social determinants of health, or SDOH, and kind of related elements there. And so there's still the similar classes of data as the first go around, but now they're that focus to kind of help promote health equity in the latest version since then. I think in general, clinical data is one we're really excited about, and we hope you are too, because I think this is where you really can start to see future ROI in a much clearer way. Of the more clinical data you have and can collate and standardize and load in one place, the more potential value you can get. And so this can power all kinds of things like risk adjustment, quality measures, pop health, care management, and lots of more. A couple more data classes I'll cover. So provider directory, this is another kind of continuation from the first go around in 9115 for you to load your in-network provider info. So, names and types and addresses of the pharmacies in your network. And so here, there's again a recommendation for an IG, which is the PDEX PlanNet IG, a more recent version since the last time. And since the first go round, these profiles inherit some of those US core standards that I just talked about. And there's just some other minor updates and fixes to just make provider directory more consumable, more logically represented, and just kind of clean that up a little bit. And then last but not least, is from the kind of required categories of data, is formulary data. And so this, again, is a continuation from the first CMS rule around loading your current formularies and preferred drug lists, what's in formulary and the plans that cover them. And here, again, it's a continuation, but the goalpost has shifted up with a new version of these IGs, linked here for PDEX US Direct Formulary. And since that last time, the big updates are kind of to help reduce duplication. There was feedback in general in the industry groups we participate in around the first version of this. It was very duplicative. You had to kind of keep copying drugs, formulary items across plans, and it was just kind of an inefficient way to load this data. And so there's been a number of changes to streamline this, make these resources kind of separate and reference each other in a way to kind of reduce that overhead. So this was quick crash course on some of the kind of categories of data changes since the last rule. I think one last type of data I want to cover is around kind of not explicitly called out by the final rule per se, but there's a number of data sets and sources that we think are helpful to kind of support the rule from an administrative or business logic or other means. And so this is not an exhaustive list, and this is not going to be applicable to everyone. It's going to kind of depend on, and we'll work with you on your specific circumstance and situation on which of these might apply for you all as you think about your getting to CMS 0057 compliance. And so, as examples and types of this data, there's if there are personal representatives in your system captured today, powers of attorney, parent-child, legal caregivers, those types of things. That is types of data that are kind of implied by this rule that we can work with. We've already have worked with some of you and can identify if that type of data is available and in scope for you. There's kind of sensitive data tagging. I know some of you, depending on the states you're in, beyond CMS, there are other state laws and just other federal laws around types of sensitive data, mental health, reproductive health, et cetera. And those need to be treated with more care and more specificity on how it's shared or if it's shared. And so that's also data we may kind of load in support of kind of achieving this interoperability use cases. So all of this data and beyond this list, I think this is also an opportunity as we're going through this effort on both as a joint effort of getting data loaded to meet the requirements and the recommendations of CMS. I think CMS is attending, it's not intending to be a ceiling, it's intending to be a floor and kind of a launch pad, as we referenced before, of how can we use this standard FHIR data to power all kinds of use cases in the future, not just the ones explicitly required by CMS.